Good afternoon. We're going to get started here today. Thank you to those who are able to join us for the next installment of our Paying for Value webinar series. Today we're focusing on measuring and rewarding quality through our quality improvement model. My name is Cade Walker. I'm a Senior Health Policy Analyst here at the Healthcare Authority. And today I'm joined by Laura Pennington, the Practice Transformation Manager for Healthier Washington, and Eddie Rouser, the Financial Analytics and Data Manager, all with the Healthcare Authority. We're going to be discussing the quality improvement model today on our ACP product, and we're going to dive into that. But first, real quick, want to make sure that everyone's logistically set up. You have two options for your audio. You can select the use mic and speakers, or you can use the telephone for your audio connection. We ask that during the webinar that you submit any questions in the Ask Question pane, and you send that to us, and we will get to that at our Q&A section at the end of the presentation. The slides will be available for download in the handout section of your screen, and will be on the Healthier Washington website after the webinar, along with all the other presentations we've done to date. If you cannot hear us now, please check to see if your speakers or headphones are turned off or are plugged in, your PC is not muted or the sound settings are correct, that your GoToWebinar sound settings are correct, or you can go to the gotowebinar.com for support, or you can just join us by telephone if you're having other issues. You can locate the dial-in number in your email that was sent out and click the plus sign in your webinar window for audio to use your telephone. With logistics out of the way, I want to go into the content of our webinar this afternoon. The primary objectives we have today are twofold. We want to present the quality measures and their measurement under the UMP Plus program, also known as our Accountable Care program. And we want to describe with a little bit more detail than we have in the past how the quality improvement model integrates with the financial incentives, tying in quality into our financial performance of the networks. As again, a brief overview of our UMP Plus, the foundational elements which we have put this program together are fivefold. Starting first and foremost with the shared risk between the purchaser and the networks, in this case the Healthcare Authority as the purchaser, and our two networks, Accountable Care networks, being the Puget Sound High Value Network and the University of Washington Accountable Care Network, where there is both accountability for the cost and quality of the care delivered to the PEB members. We also focus on the benefit design, as we talked about with the last webinar, focusing on driving patients to primary care and within a narrow network, and other benefit designs intended to improve quality and focus on value-based purchasing. We also have the intent of increasing member access to high-quality care through the program, as well as ensuring that there is adequate and timely data distributed to providers for analytic purposes and being able to adjust clinical practices as appropriate. And lastly, there's the care transformation component regarding the actual change in the practices at the clinician side, which is tied to our contracting, which will be the topic of an upcoming webinar. Regarding shared risk, we have in our contract an integrated financial and quality improvement model where one is being impacted significantly by the other. We have, as discussed in a prior webinar, the networks with financial performance and the guarantees that they have for providing the care to PEB members. And impacting that is the network's performance on quality measures and the member experience, which we closely follow for quality and ensuring improvement and setting targets and meeting national benchmarks that will limit the shared savings of the network or allow for a reduction in the deficit payment as part of the financial guarantees. And that all then contributes to the final outcome of whether the Healthcare Authority cuts a check to the networks for their financial and quality performance, or the networks cut a check to the Healthcare Authority as part of their guarantee based on the financial performance and quality. So a quick overview of the quality improvement model. This model has been established to measure performance by each of our networks on a select set of clinical and patient experience measures. We feel that it is important not only to assess the performance and outcomes in the clinical setting between the clinician and the member, the patient, but also to ensure that the patient's experience is that of quality, that the members are receiving timely care and care that is appropriate and what they feel to be of high quality. So we're assessing it both from the clinical and the member experience standpoint. The overall quality score is an integrated measure set across all performance metrics. It impacts both positively and negatively the deterioration and or improvement of any of the metrics that we have established. This model was developed with much assistance from Milliman, primarily established by our in-house HCA actuaries, and the ongoing implementation and process management is done by our in-house Chief Medical Officer, Dr. Dan Lessler. The model contains these 4 primary components that will be discussed momentarily, including the 19 quality measures, including the clinical and member experience measures, weights that are determined through contracts that are aggregated for the overall quality improvement score, mean scores established from national benchmark and other sources, as well as target scores from similar sources. So with that, I'm going to turn over the presentation for now to Laura Pennington. She's again the Practice Transformation Manager for Healthier Washington here at the Healthcare Authority.
Thank you,
Laura.
Thank you, Cade. So I'm going to briefly walk us through how we got to the 19 quality measures, and I'm not going to walk through every single measure. You can see them on your screen right now, but please feel free to let us know if you have any questions. So the 19 quality measures were derived from the Washington State Common Measure Set. If you're not familiar with the Common Measure Set was created by legislation in 2014, specifically Senate House Bill 2572, specifically Section 6, if you want to read that. And the purpose of the development of the Common Measure Set was to standardize the way we measure performance as a state, reducing unnecessary burden on health systems, and to promote a voluntary alignment of measures across payers and purchasers. So the 19 quality measures were selected. The 19 quality measures that were selected, they're based on nationally vetted measures, and they represent a broad range of health priorities, including chronic conditions, behavioral health, patient experience, preventative screenings, immunizations, and OB care. While the results for 4 of the measures are obtained through CG-CAP scores or patient satisfaction surveys, the other 14 are from either claims or clinical chart data or a combination of the 2. The depression medication management measure is actually reported at 2 rates, at 12 weeks and again at 6 months. So this measure therefore counts for 2. That's why when we say 19 and you actually see 14 and 4, if you know anything about math, that makes 18. So it's actually, the 19 comes from the fact that the depression medication management is broken out by 2 rates. So the 19 measures were ultimately selected by the Chief Medical Officer at the Healthcare Authority. As they were being considered, the criteria that was used for selection included the fact that they were included in the statewide common measure set. We asked the question, do they represent a broad range of health priorities? And does the measure have the ability to substantially impact the mortality, morbidity, and the health of the overall population? So as we work to align measurement efforts in Washington, the selection of the 19 measures were also informed by other ongoing accountable care organization efforts in Washington, such as the set of measures that are being tracked in the Boeing ACO, for example. This allows us to send one common aligned signal to providers and delivery systems rather than using an outdated silo approach. As you remember what I said at the beginning, the purpose of the statewide common measure set is to align our measure efforts in Washington as much as possible. So by going out and selecting a totally different set of measures from what Boeing was already doing, the providers would then have to start over. So because the statewide common measure set is a fluid, living, ever-evolving document subject to change from year to year, the Chief Medical Officer also has the authority to update the measures annually and does so by September 30th. Along with that, he has the authority to negotiate any new targets and weights by that date as well. So now I'm going to turn it over to Eddie Rouser, who is, what was his?
Financial Analytics and Data Manager for the Healthcare Authority.
Eddie's going to walk us through the components of the quality improvement model and to explain how it works.
The quality improvement components, each of these 19 measures is based on a scale from 0 to 100% and is assigned first a weight. The weight is how much it can influence the overall effect on the QIS score. These are set by HCA's CMO and informed by clinical literature and clinical expertise. On average, these weights are between 2 and 8%. The mean score, the average percentage for each measure, informed by the Washington Health Alliance Committee Checkup and National Committee on Quality Assurance Targets and National Data Sources. The target score, the performance that the network should achieve on each measure. Most measures target the 90th percentile or national HMO benchmarks, also informed by national benchmarks and other data sources. The weight, the mean, and the target scores are all part of a table inside the contract. The next part is the measurement values, the performance year -1 and the measurement year itself. Those are the 4 components that go into creating the basis for the quality improvement model. Next slide. So how the quality improvement model works. Each measure has an improvement score, which is the component where you're competing against how well you did last year, that is performance year -1 to measurement year, and a quality score, which is how well you're performing to the mean score and the target score of the 95th percentile or 90th percentile. The sum of the IS and the QIS measurement score, improvement score, is the QIS. Each improvement on each IS and QIS are measured for each year of the contract. The composite QIS score is generated based on the sum of the product's weight and scores for the 19 quality measures. The overall QIS score drives the share of savings and deficit payments or reductions of the deficit between HCA and the ACPs. The QIS determines either the savings share or the deficit based on the ACP's performance, and this is a key point of the cost quality model. Next page. So to illustrate an example, these are hypothetical numbers, but this would be, let's say, one measure to measure the BMI of each client. There would be 2 parts to this. There's the quality and there's the improvement for this BMI measure. And so you as a company would have your prior year -1, and then you would have a mean score and a target and a weight, which you know up front. And so what you're going to get is the measurement year out of this. So when we set the mean at 75% and a target at 95%, which would be, let's say, the 95th percentile, we would say that, okay, this is our year of 50% is where we were at, and now we know it's being measured. So after we knew it was being measured, we have a performance year of 85%. So this shows that we had improvement on the improvement score, and we had quality improvement on the quality side. So the quality improvement score result would be a 57.8%, and improvement would be an 84%, 48%. The sum or combined result is actually over 100% because we had gained on both sides, and the model allows this. And because it was weighted at 5%, the contribution to the QIS is only 5.3%. So the sum product of all measures, the other 18, this was the other 18 that would composite into the quality improvement score. For this example, let's say is 82%. So we have a positive quality improvement score. So if we have a loss or we have a gain at this point, we're going to get to either share some of the gain or we're going to get to mitigate some of our loss. So this is where the savings deficit multiplier and the effect on the quality improvement score. There's a max downside mitigation and an upside savings. And so those are also put in the contract in a table. So the ACP keeps, in this example, 41% of the profit or mitigates 21% of the loss, to illustrate the purpose. These are hypothetical numbers, and it's hard to illustrate on a slide, but it shows that one measure can play into this model and what it can do to offset. Next slide. Oh, and this is an example of the quality improvement model. As you can see, we have the source of the measure and a description of the measure, and then the table that would include the weights, the targets, and the means set points. So if the source is from NTQF or it's from the American College of Cardiology, we used those as our set points for each one of the measures.
Thank you, Eddie and Laura. This is there's no doubt about it, this is a complex model. We had a significant amount of efforts put in by our in-house actuaries and the actuaries at Milliman crafting this model that is dynamic. It allows for considerations on both the standalone quality score relative to the target, as well as how well did you improve year over year, rewarding improvement, and also penalizing degradation in quality scores. How that's been done is quite complex, and more information can be found on those models within Exhibit 5 of the contracts that are available online. And if you did have further questions, wanted to have a sit down with healthcare authorities to discuss in a little bit more detail about how our quality improvement model works, we'd be happy to arrange for that. So as we look at those of you who are in roles of purchasers and influencers in this regard, we would ask that you contact your health plan and inquire about how they're measuring quality, clinical quality performance, and member experience. We're certain that there are a lot of providers, almost all providers are using the CG CAP scores for ascertaining member experience, and inquire of your health plans to learn about those scores and those quality improvement measures to see how the providers in the network of your health plan are performing, and inquire about what sort of reward incentive they have on providers to encourage and reward those providers who are providing high quality care. You can also go to the statewide common measure set page to see how providers are performing on the particular measures of the statewide common measure set. I think there's 55 measures currently.
54.
54 measures currently. That's a lot of information available to queue up and see how providers in the network of your health plan are performing, and allowing you to know your employee population, know what measures would be critical for your employees, and ensure that you have providers available who are providing the highest quality possible for areas of concern for your employees' population. In addition, you can inquire of your health plan to adopt an approach similar to this, or this approach, in measuring quality, both clinical and member experience. Resources that are available, as I had mentioned, we'd be happy to provide technical assistance to those of you who are curious about learning more about rewarding quality and using quality as a benchmark for performance, both financially and clinically and member experience-wise for your health plan. You are available, you can go and look at the current slate of common measure sets at the website provided there, as well as having further dive in on the quality improvement model itself that's located in Exhibit 5 of the contracts listed at that website there. So I'll go ahead and open it up for questions. If you have any, I'm sure there are questions regarding the model, and we'd be happy to address those. Also in the room with me here is Rachel Quinn, Special Assistant in Policy, and J.D. Fisher, Senior Health Policy Analyst. as well to help answer questions you might have about the quality improvement model. So I'll go ahead and start with the first question that I received, which is, are the percentiles of the quality improvement model based on the previous year quality compass benchmark? I do know that the targets, weights, and means have been established for, based on the 2015 year. They were established at the outset of our contract, and those have been set in contracts and are redacted due to their proprietary nature. The improvement score is based on the performance year -1 for each of the networks, so that when the network we're calculating the improvement score, that is based off of a benchmark set from the prior performance year score moving forward to the current performance year.
Yes.
Any other comments about?
Some of the percentiles based on, I guess, our understanding of how well it was going to be used, either 80, 95th. So that was our goal, is to always map it back to a source, but we did do some adjustments.
Rachel or JD or Laura? Okay. The targets and weights and means were, due to their proprietary nature, we can't share them, but it is worth noting that those were negotiated during the contract negotiation period last year prior to implementing our ACP contract. Networks were allowed to then provide information they saw as appropriate benchmarks, and provide the healthcare authority and the chief medical officer with information that they found to be appropriate in establishing and determining the benchmarks for targets and means, as well as the weights that were negotiated during that time before final execution of the contract. Okay, other questions? Does our research
or look at other quality models?
Okay, so did the healthcare authority, did we research or look at other quality models prior to or during the development of our quality improvement model?
Yes. I think there was the quality side of the model is definitely been seen before. I think the improvement side, holding your prior year performance as either a larger percentage of the score or a smaller percentage of the score was the new part of this model. So the quality side, comparing yourself to the mean and the 95th percentile, that definitely had been done many times. The part where we're readjusting based on prior year performance and rearranging to target, that is something that was new in this contract.
I also know that the healthcare authority looked at the Blue Cross Blue Shield of Massachusetts. They have an alternate quality model contract that they have implemented that we used, I think, largely as the foundation for the quality portion of the quality improvement model. So we did use outside resources, what other states, at least Massachusetts, had been doing with one of their largest plans in establishing a quality component in our fee-for-service program. Thank you for the question. Next question we have is, what was the rationale for using the metrics from the HMO model used as the standard for our contract? Most plans do not use the HMO model, which has more controls in place than preferred provider option plans, which are the more common plan model used, or which are the more common models. I don't have a direct answer for the why, but Rachel?
Well, we did use the HMO benchmarks from the quality compass.
Yes.
Those are higher, and we wanted to.
Why did we use the HMO as opposed to the PPO? I think is the question.
We view group health as an HMO as a higher quality value-based plan that espouses the characteristics of coordinated patient-centered care. And nationally, those rates are higher, and we want providers to retain those rates.
Yeah. Thank you, Rachel. Next question. Are the weights negotiated by networks, are negotiated by each of the networks, or are they standard for both? And I think this ties in with an additional question, which is, do each of the networks have different set of measures, or are they the same ones based on the contract negotiations? I can say that based on the contracts, the 19 measures are the same for both of the networks. If you were to go through the contracts that are available, both for UW Medicine, ACN, and Puget Sound High Value Network, you would see that the 19 measures are the same measures for both networks. However, the weights are negotiated by the networks. The weights, the targets, and they're
supposed to be reviewed at a yearly cycle.
They're reviewed at a yearly cycle and are part of the contract negotiations with each of the networks.
The model could allow for that, and there was some talk of if one of the measures wasn't met, how would it drop out if one had it and the other didn't. So there is flexibility to either adjust the quality measure or drop out, or on the multipliers. So those two items are actually set the same for both plans right now.
Yeah, and I just to clarify, the targets, weights, and means are currently at the same level for both networks. Next question we have is, how do member rewards fit into this model? I'm trying to think. If we're referring member rewards, the Healthcare Authority, the PEV program currently has a Smart Health. It's a member wellness program that is really the only avenue we have for rewarding members who engage with the Smart Health program. Essentially the reward, if you were, for participation at a certain level with the wellness program is a incentive reward of $125 based on their deductible. It reduces their deductible, or if you're in one of our consumer-directed health plans, it is an increased, I think it's an increased amount into your health savings account. However, that program itself does not tie in to the member experience portion of the quality improvement model. As you recall, there are 4 member experience measures that go into the quality improvement score. Those are based off of aggregated scores from CGCAP surveys that our networks have contracted to give or to utilize and implement for the population of PEP members that they serve. So the member in himself, there's no reward within this quality improvement model, but it's their feedback on the surveys that go to the 4 scores within the quality improvement model itself. Hopefully that responds to the question a little bit. I said that the score is calculated, the quality improvement score is calculated annually. Can this calculate on a more frequent basis to assess performance over the measurement year to make changes during the year?
Currently, it's based, usually the denominator is the yearly count. So if you had an interval that was like monthly, they would have to report it more frequently, but currently that's not set up.
As the quality improvement score is calculated on an annual basis as part of the financial reconciliation process. However, the individual scores and performance on each of the measures is calculated by the networks. Thereby, they have the ability to track for themselves throughout the year what their performance on the 19 score, well, in a sense, the 14 clinical scores, they're able to track on a more timely basis given their own preference on how often they would like to spot check their performance on that. The Healthcare Authority does not require that they check into it, but it is certainly within the network's interest to be following the performance on those scores throughout the year. The 4 member experience scores, because those are based off of CGCAPs, and that would be dependent on the evaluation, the survey method that network would choose. Under CGCAPs, the survey allows for either a once annual survey that gets sent out in a one-time block to members, or you can have an ongoing survey that's sent out to patients on a plus 60 days of an episode of care to them. So our networks have different methodologies for their surveying, so the spot checking on their member experience scores would be dependent on the method of surveying that they use. Thank you for the questions. Are any other questions coming in at this time? Any other comments from our panelists or other people in the room here today? Okay. I want to, pardon? Yeah, I think we had some great questions on a very complex portion of our accountable care program. In wrapping up here, we're going to get you back about 25 minutes of your day. I wanted to let you know that our next webinar on care transformation will be on August 8th. This will go over the components of our contract, primarily in Exhibit 1.2, if you want to get a little bit of pre-reading done about what we will be discussing at the next webinar. We will have our Chief Medical Officer, Dr. Dan Lessler, and our Special Assistant for Clinical Quality, Barbara Lance, giving the presentation on the 8th. And you can register at the website provided here. If you have additional questions, I welcome you to reach out to Rachel Quinn at her email listed there, and we will respond to anyone who has additional questions after the fact. I thank you for your time this afternoon. I hope you were able to learn a little bit more about our quality improvement model, and look forward to having you attend another future webinar on our Paying for Value series. Thank you and good afternoon.